capturing ANC4. We have very few mothers that are coming, and we are capturing it at 56%, which is a very low, which is that needs to be addressed. And that is why we are here together. We are going to put our minds together and see how we can improve this indicator. Next, please. Now, a drug we call IPT. So now we have that with malaria in pregnancy, is still high. We need. This is HIV testing during pregnancy. In actual sense, all mothers that attend antenatal must be treated, must be tested for HIV. When we look at the facility-based deliveries, because of time, we are now looking at 2024-2025. Thank you. We are at 71%, which is not good enough. This is an indication that mothers are still delivering in the community. So, together we shall look at why do we think mothers are delivering in the villages and not coming to health facilities. Next, please. Here we are comparing. There is a vaccine that is given to babies when they are born. This vaccine is given to babies at birth. So we are comparing, this vaccine is called BCG. We are comparing it with the live births and the estimated deliveries. This bar indicates that we are still having more deliveries. And there is a time when you are going to look at this vaccine is higher than the deliveries. The question, where do this deliver from? Next. So we are having maternal deaths, and currently as Kasese, we are at 22%, which is unacceptable. Together we can do something to reduce this number. But I thank the facilities, they are notifying and they are auditing. Because of time, I will have explained what auditing is and what notifying is. Next, please. Now, we are looking at this slide, we are looking at the number of perinatal deaths. Perinatal deaths, this I mean, I will call them babies. Babies from 7 months up to 1 week post-delivery. Those who die during that process. Others die in the womb and others die 1 week after delivery. So this is the figures. Next, please. Now, here we are looking at different health facilities, the number of perinatal deaths they have, and those that were audited and those that were not audited. We have different facilities that have cases that have perinatal deaths but have not audited them. We are looking at different health facilities performance. Next, please. Next is the same. Now, challenges during support supervision. During our support supervision, I have divided it into 3 because of time. When we look at antenatal, we have both challenges with antenatal and we have late antenatal care attendance. First, remember we said first trimester is within the first 3 months. So we have attend late. Then we have for ANC, we are still at 56%, which we need to improve. And we have in antenatal clinics, we are supposed to have screening for high-risk mothers and to attend to these mothers individually. So in most health facilities, this is not attended to. My humble request is let us try to form a high-risk clinic in different health facilities, and we have also increased the number of in maternity ward. I'm saying these are the findings we are getting when we are doing support supervision. In labor ward, members in labor ward we are supposed to monitor mothers using a pantograph. But as we perform support supervision, we find that mothers being monitored during labor, which is a problem. Please, in charges, just make sure we supervise our staff and make sure that they monitor mothers. These partners supporting MCA so that we see how we can coordinate. And also in facilities, we observe the facilities. Yes, please, thank you. As you saw, we said tests and reviews are not done in most facilities. We are requesting that so that this is not repeated. Thank you so much for listening to me.
I gave her extra time because MC8 is the oxygen of health department. You can't survive minus MC8. Other departments and what have you can become backbones, but with this one, it is oxygen. That's why I gave her extra time. So the next one, Dr. Albert Zaki. We talk about application of MPTRS coordination in the district. Where is the doctor?
Thank you so much, Chair, for this session. My name is Dr. Fo, and we are trying to bring it up and given them. I'm going to use only 5 minutes for this, and I go to the next for the 10 minutes. Thank you. For the call why we are here today, we must fight these preventable maternal and perinatal deaths. And our goal is to reduce maternal and perinatal mortality in the district by having functional MPDSR committees at all levels. It is so sad that even in this center we are in, some health workers, when we talk about MPDSR, they feel as if it is another bird coming from another planet. We are in things that are changing, we are learning new things, and the approach now is and we need to do that to make sure that we review all our mothers, all our babies that have had bad outcomes. So our progress community platform, and that is every Monday from 2 to 4 p.m. every Monday we have a meeting, we have an engagement, and that in your facility in the past 1 week, and we have that platform contacts, and we embrace and we put it on the platform. The other thing is the health facilities and the district provides updates on the situation of MPDSR in the areas of jurisdiction. In that accountability time when we are reporting, we even account for how many deaths have we had in your facility for that week. And even you tell us, have you notified those cases? Have you reviewed those cases? And it doesn't end there, we want evidence. And the evidence will be shown by the hard copies you have. And we have said every bad outcome in your facility, we need the hard copies at the ADHO's office. I repeat, everyone with a bad outcome at your level facility 2 or 3, we need the hard copies at the ADHO's office. We want to track perinatal deaths. You get a perinatal death and you don't audit and you keep it silent. There's no way we are going to improve if we don't have those cases audited and they will find out what is causing the death. Because the ultimate reason why we review those cases is to change and look for solutions that are locally within our local setting to be able to curb this issue of prenatal deaths. Then we are doing follow-up on health facilities, maternal deaths and prenatal deaths in auditing. Apparently, if you have a death that has happened in your facility and you keep quiet, we shall know and we shall come there privately and get the actual information. When you conceal a death, you are killing yourself because you will not learn. And reviews are not there to criminalize anyone. They are there to help us improve and work out best practices that are going to make us be able to prevent the next death that can happen or the next case of the mother that may come with a similar problem. So colleagues, we want to end this one of MPDSR here. We are saying let us have functional MPDSR committees. Any challenge you have in functionalizing them, let the DHT office get the know that we're able to support you and be able to know that you're with us and we journey together. If all of us here embrace LPDSR, we are going to fight this issue of perinatal death in our region. Because we don't need to discuss about coordination, how we coordinate with one another to make sure that these cases are.
When you look at your program, there is a presentation of MCH across Brazil training. That one has been covered by the ADH code in charge. So we attempted that one. Thank you for that presentation you have just given us. Can you straight away go to the other one, which is the presentation of basic practices? I think it is good to cover that.
Thank you so much. Yes, that one is for 10 minutes. Now, thank you so much, Chair. I was working with the Nyamira Health Center at Nyamira best practices. We know the many practices we are having at our facilities, the standard ones. But we are looking at what are those extra things that we put in place to ensure and make sure that our MCH activities are running and are well coordinated. And that's what we are looking at. Next. So the main issue the main objective for this presentation is to review the evidence-based maternal and newborn care practices, to highlight successful interventions from our local context. You may not need so much resources, then to share actionable recommendations for implementation. Why do we need best practices? The ultimate thing why we need this is quality care directly improves maternal and newborn outcomes. The outcomes in MCH. And these days we are calling it for the mothers that we are offering what respective maternity care. That is a game changer. We want, if you have best practices, you will prevent. You have preventive measures that are cost effective. You will not require so many costs. If you have a mother who has anemia and you have recognized this one early, you have treated it early, when the mother goes into labor, she will deliver and will come out well. If you don't pay attention to that anemia, the mother will go into PPH and you will struggle, you need blood, you need transport, you will move up and down. So preventive measures are very key. If you use them, you have costs, you will save your costs. But all these are aligned with our SDG number 3, health and well-being. When you are well, then SDG, sustainable development number 3 says we must be healthy and have a good well-being. You can't do this if you don't have quality health care in your facility or what you're offering to your community. So, we are going to look specifically at the areas. The first thing is antenatal. Among other things we are offering antenatal, what have we done? What did we do? We had to introduce a high-risk clinic. And this high-risk clinic was basically dealing with identification, retention, linkage, and response to all high-risk mothers that attend antenatal. And how do we do it? We made sure that our antenatal should run every day. We got a day within a week, and that's the Wednesday when we run a high-risk clinic. All mothers who are sitting at natal during the week and the high-risk mothers are immediately linked to the high-risk clinic, which runs every Wednesday. And the game changer in the high-risk clinic is the doctor's presence in that clinic. The doctors here, if you don't support the midwives in the high-risk clinic, it will collapse. I repeat, the doctors here, we must support our midwives in the high-risk clinic for it to become successful. We are not going to be helicopter doctors like Dr. Muga calls us. You are on duty, you are on duty. You are on duty, you are not on duty call. No, you are on duty, you are on duty. Now, our dental clinic was running every day, every week, every day. Initially, when we were starting this innovation, we used to have only 3 days in antenatal, but that was a big disservice. So we had all the 5 days we have to have antenatal and also increase on the outreaches for ANC and to be able to have all these mothers with that mother so that you can journey with the mother until they get a good outcome. Next. During labor and delivery, we still continue with the identification. Some people think we live in antenatal, and this is what we have been calling upon every Tuesday in the regional IRR meeting of every morning. We discuss this and we say identification does not end in ANC. It goes up to labor and delivery. And what we have done currently in Yamirami, we have introduced color codes. Every time the mother is in a code, we have code red, code yellow, and code orange. The red is has more than one risk factor in pregnancy. The yellow means you have one. The green you in a second risk factor. So you can walk in on maternity ward and get the admission terms of mothers and look through and you can even say this is the high risk, this is the high risk, and easily you are following through. Even when there is over, the person being handed over will look at those stats and pay attention to those specific mothers. It has worked, it is working. And we are running a project, a 2-wide project on that specifically coding. Are we clear? So we've successfully finished another 2-wide project about complete and accurate documentation in the maternity register. One of the facilities we visited in this one in these weeks, we found the maternity register. Mothers who are admitted in 2023 are still admitted. 2023, they are still on board. There is no evidence in the register that they were discharged. So they are still admitted. So I wonder how you come with the report and how you calculate the bed occupancy rate. How many days of stay are you going to calculate? When in the register there is no evidence of discharge. We must be accountable to all these cases we are to know, successfully journey with them and exit them in our register. That would be a very good practice and will make the work of the doctors early enough. Don't wait to have a complication and now you call. But it's our duty as doctors to be there in the process of delivery. Next. In newborn care, when you look at the delivery, we also consider the children, the unborn. You must be able to identify that this child that's going to be delivered may have a risk. And some of them may be, if you have not used the pantograph, like Sister said, you will not identify which child is at risk of fetal distress, at risk of having mother's asphyxia. So we must make sure that we anticipate that this child is likely to get asphyxia, and therefore your preparedness for the healthy baby breath must be well set and well placed for you to have a successful resuscitation for this newborn baby. But every time you have to document and you have to review every mother upon delivery. The first 2 hours are very, very critical for us to review these babies and these mothers that have delivered. Those first 2 hours are very critical, but you can move up 6 hours, then you can do a follow-up up 6 weeks for you to be able to follow up. What are some of the successes? Some of them are already mentioned in them. This is just a matter of emphasis. A functionalizing a work improvement team. Every Monday morning at Nyamira the maternity ward, the staffs will sit and review the previous week. If there's a bad outcome, they review it. If there are successes, they will review them. They will try to look at what has happened in this week and what can we improve in this week. And then also consider the documentation. And in this meeting, sometimes we are very intentional. We even tag those who are making us fail to work well. put that there. But now in discussion, we tell you, Dr. Alice, you are supposed to review this matter, you need to review the matter on time. We might go to find out at least next time when you are called upon. It is the WHO standard says when you are called upon as a doctor, the maximum you can take is 1 hour for you to answer that matter. But within 30 minutes, the doctor should have reviewed any matter that has been called to be reviewed. So we discussed all that, and we have had various trial projects, and we are going to see them somewhere. We always have a quarterly performance review for the facility. Every quarter, as the facility, we sit and we review our performance. Because at one time we lost money in terms of RBF. When they came to review us from the ministry, they were mismatching figures in terms of performance. And they told us, honestly, you're losing this money, and it went. So we said, no, if anyone is going to make us lose the money, we shall go in your name. So we hold performance review meetings every quarter to see what is documented and what our control officer reported in the system. We also have a functional MPDS committee. That committee is the one out that credentials. We have had credentials, but none of them is not audited. And you reach there, the file is well set and well clear. You will come, get the file, and see all our proceedings for that financial year. Yeah? They even had some areas, the cases we have, and they almost see they were about to die by the zip and we saved them. Those are the ones called near misses. We have had presentations at both the district level and also the regional level, and hope also to be at the national level. But also community dialogues, community engagements. We engage with the community, at least in a quarter. We cite the problem. When we had issues of teenage pregnancies, we cited an area where they were coming from. That community and discuss what could be the possible complications of teenage pregnancies. These are some of the pictures. Good. So quarterly performance, the pictures can see volumes. Next. High-risk clinic, and then we provide high-risk register. In facility, they say we don't have one, we don't have the register, but what we provide, we started with this format. This is where we started from. This one. Currently, we have the one for the ministry, very big like this. So it's not saying that I don't have, you can start with whatever you have and you transition. And that's why we are calling them best practices. And I was there. Giving what? Health education. You see our staff were in the community dialogue, we were trying to engage, and this was the market. We collected them, we strengthened them, we discussed with them, gave us attention, we spoke with them. Next. And that this is what has been transferred. In 2023, we had total attendance of 1,936, but because of our intervention, we have seen improvement. The service in the section of the 6 and this is in the section. Power is gone.